I think that's a good time to hand back to Lane to let him take you on a little journey for a bit.
Dots, love dots. This is Sonia. Sonia came into my practice seeking a second opinion, and typically, we start out the conversation asking something like, well, how can I help you today? And right out of her mouth, my temps keep falling off. Well, who can't look in a mouth like after saying that? And when we take a quick look, we see that her full maxillary arch is in a provisional. She's missing some teeth. There's a couple of implants in place, but what caught my eye, probably catches yours, is the extruded reinforced ZOE around the central, and thinking, oh, great, that thing's broken. But when we talk a little bit more, it turns out she's been in some sort of provisional restoration for the last 5 years. So the real question is what we see more important than what we ask? And so when we talked a little bit more, she goes, well, my jaw joint hurts and sometimes it pops. I know all of you are looking at the provisionals going, really? And interestingly enough, she stated, but it didn't before I started this work. So she was starting a replacement of old fixed restorations and ended up in this situation. We're all creatures of habit, right? So the first thing I did is I took some radiographs, and fortunately there was no burned down Indian village underneath the provisionals, and that central seems to be intact for the moment. I want to speak to something that Avron King spoke about, and that regardless of your technical expertise, unless you had the behavioral skills to communicate, meaning the ability to profoundly listen to your patients, your technical skills would go largely unused. I love this graph on the right that I got from Jeff Okeson. He talks about what drives patients, what inputs. If a patient wakes up with an abscess, they're in pain, physical. They want to see us, get them out of pain. They go away. The issue occurs is when the problem does not resolve quickly, and a lot of time, like in Sonia's case, is allowed to pass. And our input diminishes from physical and becomes much more emotional. So we need to talk, we need to learn, we need to observe. Daniel Kahneman speaks to the concept of Wysiati. What you see is all there is. And what this theory states is that when our minds make decisions, we deal primarily with known knowns, phenomena we've already observed. And we rarely consider known unknowns, phenomena we know to be relevant, but about which we have no information. And it's our job to find that information. In other words, our minds do not account for the role of chance. And we falsely assume that future events will mirror past events. Read success into that. So, what does a restorative dentist do that's trained in occlusion? I take mounted casts, I take face-bow transfers. And I just inverted the picture so it's easier to see what I'm looking at. And so I see space in front of the anteriors, and I see a contact on the second molar. So I said, oh, I'm dealing with a slide. Looking at the other side, flipped over again, I see lots of space, no contact. I said, all right, so we have a first centric contact on that second molar, and obviously it's an AP as well as a lateral slide. Yeah, well, if you look a little closer, and then after I looked a little closer, I said, oh, look at where the first contact is, and where that contact lies in relationship to the mounted casts. It falls between the two segments of the provisionals and is actually beginning to separate. So what are we really dealing with here? Is it a pivot now, or what is it? Should we be repositioning more? Do we need to find CR? Is that the question? Or maybe the more important issue is that we determine the degree of parafunction in a patient like this. And this is Sonia's maxillary anterior midpoint stop appliance. And you can see we applied the black Sharpie, as Mike spoke to. And this is her anterior-posterior parafunctional pathway recorded from nighttime to daytime. That's pretty excessive. And so, interestingly enough, when I went back and looked at her mounted casts, that's exactly the same distance that she travels. And what's really kind of fun when you really start looking, at things, and let's look at what are the cuspids in this provisional, you can actually see there is a lateral stroke about the same length, and if you look at the other cuspid, that kind of pattern becomes very apparent. So the question is, should it be, what is CR? Or is the real question, where is CR? Yeah, I love this statement from Lyle Johnson, long considered the poet of dental literature. Indeed, it could be argued that the progressive modifications in the definition of centric relation, as Mike spoke to, has done more to eliminate centric slides than 20 years of grudging acquiescence to the concepts of nanology. Like, that's perfect. And at one time, we tried to qualify a healthy joint position. And these measurements from transcranial x-rays came from Solonit's textbook. And when asked where these were referenced from, these are actually numbers collected by Dr. Robert Ricketts, an orthodontist in the Pacific Palisades area of Los Angeles, where he took transcranials of all his orthodontic patients, collected data points for years, and came up with these measurements. Now, what's kind of interesting about Ricketts is I further learned that Dr. Ricketts, would visit the gross anatomy lab at the dental school, actually take cadavers back to his private practice, take transcranial radiographs, write a report, return the cadaver and the sealed report to the anatomy instructors, ask them to dissect out the joints, and I've heard with 100% certainty that they actually found exactly what he told them he would find. And so I'm just fascinated that someone would actually drive a cadaver across Los Angeles to their practice and drive it back. But if you understand traffic in Los Angeles, maybe this is the way he utilized the carpool lane so he could get back and forth a little bit faster. How about better tools? CBCT. I think we're all pretty comfortable with the fact, and it's been shown, that we can use a Cobalt balancer to locate centric relation. And in the bottom study, a very interesting study, they took a couple of experts who were blinded to where the CBCT images were taken, and then they all said within 100% that they felt that the most theoretically ideal seated joint position was the image taken at the apex of the Gothic arch tracing. And this is Sonia's CBCT. And what do we see? She's distalized. Somehow in MIP, she is distalized, so the pop is easily explained by the running start she has to get back onto the disc and eminence. So it's time for some new provisionals for a couple of reasons. If anyone remembers staring at that first picture of her provisionals, there was a hole in it that was repaired. I couldn't quite figure out why that was. And then I figured it out when I took off the provisionals and started to unscrew the healing abutment on the implant to utilize it for a new provisional. I kept screwing and screwing and screwing and hit that pause where, something didn't quite go the way you wanted it to, and you get real quiet because you don't know what you're going to say next. So I'm holding the implant in one hand, and kind of staring down the hole it left behind and realizing that the threads had cut into the central as well. So my poor central that I thought was lost in the beginning is still going to be lost. So we're going to fabricate a new provisional, send her to the surgeon, get an implant, new implant in 7, 8 out, and a new implant in 9. And you can see the provisionals on the right where we're starting to work out her aesthetics, but more importantly, we're trying to find a more orthopedically stable position for her. We're now taking a page out of Pankey Man Schuyler. And by utilizing precisely adjusted provisional restorations and working out the occlusion in those, we won't have to do a remount, which is a great thing. And again, Mike talked about these hallway discussions. I was part of them. I was great. I mean, I learned so much. Long-centric. Or maybe we should call it freedom from centric. Or some said it was just sloppy technique. You hadn't located CR, right? I think it's just a bad definition. When we look at topography of teeth, do we want something that we see on the top part of the screen? Teeth with deep fossa, lots of supplemental anatomy, sharp cusps. Or is what we see on the bottom part of the screen really what we should be striving for, right? Teeth with flatter stamp cusps, the ability to have a landing pad for support and allow for some slight forward movement. I want to share a video that was provided by Dr. Javier Vasquez with me, showing opening and closing. And I want you to note the first motion of opening is not purely a hinge. It's a hinge and translation. And Mappelli showed this using 6 high-speed cameras and strategically placed markers, that the first opening is not purely rotational, but a combination of translation and rotation. With translation becoming more contributory, the closer you get to MIP. You can see it in opening in the yellow and in closing pathways in the purple. So we know that one contact per posterior tooth will provide adequate support. We can either buccalize or lingualize, depending on which tooth it is, the occlusion, with a cusp tip occluding on a flat plane, as Mike spoke to. And that's the philosophy we used on Sonia. This is an impression, a cast of her definitive restorations. And if we look at the distribution of our dots, they're nicely bilaterally placed, and they're all on the lingual cusps. This is Sonia's definitive metal ceramic restorations. The occlusal view of her restorations, as well as looking at her anteriors. She's symptom-free at this point, but now this brings us full circle back into the discussion. What's really more important? Is it the posterior determinants? Is it the condylar pathway? Is it the anterior design? What is it? Well, Mike and I propose to you that what's really important is locating a precise static joint position that allows us to design and manage the destructive anterior forces in dynamic movements.